Asthma, what is asthma? Asthma is a reversible constriction of the bronchioles due to hypersensitivity to certain allergens. What are the risk factor and causes of asthma? Someone with a personal or a family history of atopy. What is atopy? Atopy is basically a genetic tendency for hypersensitivity reactions. So, uh, personal or family history of atopy is an important risk factor for the development of asthma. Patients with asthma also tend to suffer from other IgA mediated atopic conditions. What are the other some associated conditions that can be associated with asthma? They include atopic dermatitis or eczema, allergic rhinitis or hay fever, and antenatal factors such as maternal smoking and viral infection during pregnancy. They can also lead to asthma in children. Viral infection during pregnancy, especially respiratory syncytial virus infection with respiratory syncytial virus, can expose a person to asthma later in life. Low birth weight and not being breastfed, maternal smoking around child. These are some other risk factors or causes of asthma. Remember that the patient with asthma are also sensitive to aspirin and NSAIDs. Remember that aspirin and NSAIDs, they inhibit the synthesis of prostaglandins and they increase the synthesis of leukotrienes. So if the person is having asthma, his asthma will get worsened with the use of aspirin or NSAIDs. So aspirin and NSAIDs are contraindicated in patient with asthma. Can someone tell me one more drug that can worsen the symptom of asthma? Anyone? NSAID and aspirin. And I need to know one more drug.
Beta blockers?
Yes, that's right. Excellent. So beta blockers, aspirin, and NSAIDs, they all will worsen the symptoms of asthma. So remember this mnemonic that BAN, B-A-N, BAN drugs are contraindicated in patients with asthma. B for beta blockers, A for aspirin, and N for NSAIDs. Occupational asthma is when a person have symptoms of bronchoconstriction during the working days or working week and no symptoms at weekends. So if a person is having symptoms during the working days and he does not have any symptoms during weekends, then most probably he is having occupational asthma. Either the person is having symptoms during the weekdays or there is a reduced peak flows during the weekdays and normal reading when he is not at work. So if such patient present to you with such kind of symptoms, Then you will think of occupational asthma. People who are working and have an exposure to isocyanates or fluor, they can develop the symptoms of asthma. What are the common symptoms with which a person with asthma can present to you? They include cough that is worse at night, dyspnea or shortness of breath, and chest tightness. So remember these three important symptoms, that is cough, dyspnea, and chest tightness. Cough is usually worse at night. So remember these three important symptoms with which a person with asthma will present to you. And what are the signs? On auscultation, there will be expiratory wheeze, and on a peak flow meter, peak expiratory flow rate will be decreased. So three symptoms and two signs, they are important to remember. Cough that is worse at night, dyspnea and chest tightness. And on auscultation, there will be a wheeze, expiratory wheeze. And because of obstruction to the air during expiration, peak expiratory flow rate will be reduced. Some exam tips to make a diagnosis of asthma. Remember that the symptoms of asthma are worse at night or early in the morning, because during evening or night or early morning, the level of hormones such as cortisol and epinephrine, they are decreased. Stress hormones such as cortisol and epinephrine, their level are decreased during nighttime and early in the morning. That's why the symptoms of asthma gets worse at night or early in the morning. So sometimes in the exam, this may be a hint to make a diagnosis of asthma. That is chest tightness or cough or dyspnea that is worse at night or early in the morning. A second tip to make a diagnosis of asthma is that the symptoms may sometimes be triggered by specific allergens such as pollen, wet, cold air, or perfume. And we have already discussed that the symptoms, if the symptoms of cough or chest tightness, they get worse with taking aspirin, beta blocker, or NSAID, non-steroidal anti-inflammatory drugs, then again you will suspect a diagnosis of asthma. So someone with a cough presented to you with a cough that is worse at night, or whose symptoms gets worse with the use of beta blockers, aspirin or NSAID, and there's an expiratory wheeze on auscultation, you will suspect asthma and you will confirm the diagnosis. The diagnostics test to confirm the diagnosis of asthma is spirometry. Spirometry with bronchodilator reversibility test. So remember that spirometry will show, we measure two things on spirometry to make a diagnosis of asthma. One is FEV1, that is forced expiratory volume during the first second. What is FEV1? FEV1 is forced expiratory volume during the first second of exhalation. The volume that has been exhaled at the end of first second of forced expiration. Because there is obstruction to expiration or during expiration, bronchoconstriction occurs. That's why FEV1 will be decreased in obstructive conditions such as asthma, COPD, bronchiectasis, and cystic fibrosis. FEV1 or forced expiratory volume at the end of first second will be decreased in patient with obstructive lung diseases such as asthma, COPD, bronchiectasis, and cystic fibrosis. The second parameter that we measure during spirometry is FVC or forced vital capacity. Forced vital capacity is the volume of air that has been exhaled after a maximal expiration following a full inspiration. So a full inspiration and then a full or maximal expiration. So the volume of air that has been exhaled after a maximal expiration following a full inspiration is known as forced vital capacity. Forced vital capacity, remember from its name, forced vital capacity, the amount of air that is exhaled after making a full force. So how we diagnose asthma and COPD and other lung condition on spirometry? We can diagnose these condition by calculating the ratio of FEV1 to FVC. FEV1 over FVC ratio is calculated to make a diagnosis of obstructive lung diseases or restrictive lung diseases. Now remember that the normal value of FEV1 to FVC ratio is 70% or 0.7 in normal people. Normally, FEV1 to FVC ratio is 70% or 0.7. So if the answer of FEV1 to FVC ratio is 70% or 0.7, then we'll say that it's normal. Now FEV1 is written in the numerator and FVC is written in the denominator. Now in obstructive conditions, the volume of air that is expired during the first second is decreased, but the total volume of air that is expired after maximal expiration is normal. There is only a decrease expiratory air during the first second, so only FEV1 is decreased in obstructive lung diseases. So what will happen if the value that is written in the numerator is decreased, but the value that is written in the denominator will remain normal? FEV1 over FVC ratio will decrease. It will become less than 70% or 0.7. So if on spirometry, the FEV1 over FVC ratio is less than 70% or less than 0.7, then we will say it's an obstructive pattern of spirometry. FEV1 over FVC ratio of less than 70% or 0.7, we will say it's an obstructive pattern of spirometry. Now, if this ratio is increased, or if the ratio is more than 70%, or if it is more than 0.7, then we will say it's a restrictive pattern of spirometry. So obstructive pattern will be if the ratio is less than 70% or 0.7, and restrictive pattern will be if the ratio is more than 70% or 0.7. If there is obstructive pattern of spirometry, then the diagnosis can either be asthma, it can be COPD, it can be bronchiectasis, it can be cystic fibrosis. These are the examples of obstructive lung diseases. And if the ratio is more than 70% or 0.7, then the diagnosis will be restrictive lung diseases, such as idiopathic pulmonary fibrosis, interstitial lung disease. So they are example of restrictive lung diseases. Now on spirometry, there is obstructive pattern, that is FEV1 or FVC ratio is less than 70%. Now it can be asthma or it can be COPD. Now how we can differentiate between asthma and COPD on the basis of spirometry? After doing spirometry, we'll do a second test that is known as bronchodilator reversibility. Remember that in asthma, the bronchoconstriction is reversible bronchoconstriction due to hypersensitivity to allergens, while in COPD, it is irreversible obstruction to the flow of air during expiration. So to differentiate between asthma and COPD on spirometry, we do a bronchodilator reversibility testing. What we do in that test, in bronchodilator reversibility testing, we give the patient an inhaled bronchodilator, such as salbutamol, and then we measure the FEV1 and FVC values after giving a bronchodilator. If this ratio improves, if the FEV1 over FVC ratio improves, if it's become more than 70% or 0.7, then we'll say that it's a positive bronchodilator reversibility test, and the diagnosis will be asthma. And a negative bronchodilator reversibility test will indicate a diagnosis of COPD. So is this point clear to everyone? How to differentiate, how to diagnose asthma and COPD on spirometry, how to diagnose obstructive lung diseases, and how to diagnose restrictive lung diseases, and how to differentiate. What?
How differentiate?
Differentiate between asthma and COPD?
Yes.
So first of all, the first point that you need to remember is that in asthma, there is reversible bronchoconstriction. And in COPD, there is irreversible bronchoconstriction or irreversible obstruction. So first we did a spirometry, which showed a person present to us with shortness of breath, because asthma and COPD, both of them can present with dyspnea. So now we are going to make either it is asthma or COPD. First of all, we'll do a spirometry, and the spirometry will show decrease FEV1 over FVC ratio. That is less than 70% or 0.5, 0.7. So if FEV1 over FVC ratio is less than 70% or 0.7, it can either be asthma or it can be COPD. Now, the second test that we do to differentiate between these two is to give a short-acting bronchodilator, such as salbutamol, to the patient. And then after giving this bronchodilator, we again do spirometry. Now, if the person is having asthma, what will happen? The bronchodilator will dilate the bronchioles, and the FEV1 over FVC ratio will improve. It will become 70% or more than 70%. Then we will say that it is asthma. And we'll say that bronchodilator reversibility test is positive. So if bronchodilator reversibility test is positive, then it is asthma. And if this test is negative, if the ratio does not improve after taking a bronchodilator, then it will be COPD. Is it clear now?
Yes, sir. Thank you.
So someone with the features of suspected asthma, the diagnosis will be confirmed on spirometry plus bronchodilator reversibility testing. Another test that can be used to make a diagnosis of asthma is fractional exhaled nitric oxide, also known as FeNO, fractional exhaled nitric oxide. Remember that nitric oxide is produced by three types of nitric oxide synthetases. And one of the type of nitric oxide synthetases, that is inducible nitric oxide synthetase, is present in the inflammatory cells, especially eosinophils. So if the level of FeNO are increased, then it means uh, high eosinophils or inflammation is present. Inflammation of the airway is present. So a normal value of fractional exhale nitric oxide for adults is less than 40 parts per billion ppb. If fractional exhale nitric oxide is more than 40 ppb, then we will say that it's positive and there is inflammation going on or the person is having asthma. And for children, the normal level is less than 35. So in adults, a level of 40 or more than 40 ppb is considered positive. And in children, the level of 35 ppb of FeNO is considered positive. And on spirometry, FeV1 over FVC ratio of less than 70% is considered obstructive. And reversibility testing, if there is an improvement of FeV1 of 12% or more, or an increase in the volume of 200 ml or more after a bronchodilator, then we will say that the reversibility testing is positive. So after a bronchodilator, an improvement of FeV1 of 12% or increase in the volume of 200 ml or more is a positive reversibility test. So in short, three tests can be used to make a diagnosis of asthma. The first of them is spirometry, followed by reversibility testing, and then measuring the fractional exhaled nitric oxide levels.
Can you
This
explain the nitric acid one again, please?
nitric oxide is synthesized by three types of nitric oxide synthetases. That is an enzyme. So there are three types of enzyme nitric oxide synthetases that synthesize nitric oxide. And one of them is inducible nitric oxide synthetase that is present in the eosinophils. So if you measure the exhaled nitric oxide and it is increased, it is 40 or more than 40 ppb, then we'll say that FeNO test is positive. So inducible nitric oxide synthetase is present in the eosinophils. So an increased nitric oxide or exhaled fractional nitric oxide means increase in the number of eosinophils, and increased eosinophils indicate uh, the diagnosis of asthma.
Okay, thank you.
So spirometry with reversibility testing and fractional exhaled nitric oxide. These are the tests that can be used to make a diagnosis of asthma. in patients who are above 5 years of age, 5 years or above 5 years of age, these tests can be used. All of these three tests. And if the patient are less than 5 years of age, then the spirometry and FNO, FENO are difficult to perform. That's why the diagnosis should be made on clinical judgment in patients who are younger than or less than 5 years old. We usually wait until the child become 5 years of age, and then we do these tests: spirometry, reversibility testing, and fractional exhaled nitric oxide. Again, some exam tips: how to differentiate asthma from COPD. The one way to differentiate between them is that reversibility testing. So can somebody please tell me how we can differentiate between asthma and COPD on reversibility testing? Who will revise this point?
In asthma, there is reversible bronchodilation, while in COPD, it will not happen when we are giving bronchodilator. So in this way,
how much
yes,
improve in FEV1 indicates a positive reversibility test?
more than 70%.
Yes, if the value become more than 70%,
Then this is
or
asthma.
even 70%, then it will be a positive reversibility test, and that indicates asthma. Other points that can be used to differentiate between asthma and COPD is COPD is rarely totally refractory to medication because there is permanent bronchoconstriction or permanent obstruction to the flow of air. And another hint will be that the patient with COPD either they smoke or they have a history of smoking in the past. So smoking is an important risk factor for the development of COPD. So positive reversibility and negative reversibility test is one differentiation factor. The other one include that patient with COPD will have a history of smoking. And these 2 points are important to differentiate between COPD and asthma. Remember that asthmatic can also develop COPD later in life. If they have a long-term asthma, they will also develop permanent or irreversible obstruction to the flow of air later in their life. So that's why it's important to know the differentiating point between asthma and COPD. Now, long-term management of asthma in adults. How we manage asthma in adults? The management is very simple. There's a 7-step management for asthma treatment according to NICE guidelines. So the first step in the management of asthma is to add a short-acting beta agonist, SABA. Short-acting beta agonist. If person is not controlled on step 1, then we will go towards step 2, that is SABA plus we'll add low dose inhaled corticosteroids, ICS. So a person not controlled or on this short-acting beta agonist, or a person who is diagnosed with asthma and he is having symptoms for 3 or more days a week or nighttime waking. So if the person asthma is not controlled on the step 1, or if he is having symptoms for 3 or more days during a week and there is nighttime waking as well, then we will add low dose inhaled corticosteroids along with SABA. So first step is SABA, second step is SABA plus ICS, inhaled corticosteroids. And in third step, we'll add a leukotriene receptor antagonist. Remember that we are discussing a NICE guidelines. BTS guidelines, British Thoracic Society guidelines are different from NICE guidelines for the management of asthma. So in first step, SABA, in second step, ICS, in third step, LTRA, leukotriene receptor antagonist. And in fourth step, we'll add LABA, long-acting beta agonists. So in first step, SABA, in second, ICS, in third, LTRA, leukotriene receptor antagonist. In fourth step, we'll add LABA, long-acting beta agonist. And we'll continue LATRA or LTRA, depending upon patient response to LTRA. So till fourth step, we have added four medication: SABA, ICS, LABA, and LATRA. Now we have add all the medication. Now what we are going to do in step 5? Step 5 is very simple. SABA plus minus LATRA, and we'll switch ICS LABA for a maintenance and reliever therapy. Remember that maintenance and reliever therapy is a type of therapy in which we use inhaled corticosteroids and long-acting beta agonists for both maintenance and reliever therapy whenever it is required to relieve the symptoms of asthma. We use ICS and LABA. They usually come in a single inhaler. Till fourth step, we were using low dose inhaled corticosteroids and LABA separately in separate inhalers. But in step 5, we'll shift this ICS and LABA to a single inhaler that is known as maintenance and reliever therapy. That inhaler will be used for maintenance of the symptoms and to relieve the symptoms whenever required. So in till fourth step, we'll add all the 4 medication, and in the fifth step, we will switch the ICS and LABA to a combination therapy in a single inhaler that is also known as maintenance and reliever therapy, or MART. Remember that the dose of inhaled corticosteroid till fifth step is still low dose inhaled corticosteroid. Now, what we are going to do in sixth step?
Can you please repeat the fifth step? It's a bit confusing. Fifth one, please.
Okay. So till fourth step, we have added 4 medication, that is SABA, ICS, LABA, and LATRA. We have added all the 4 medication, but if the person is still having symptoms. Now the fifth step is a little bit tricky. So SABA and LATRA, they will be present in all the steps. In fifth step, in sixth step, and in seventh step. This is the common one, SABA plus LATRA, or leukotriene receptor antagonist, plus minus. It can be used or it cannot be used depending upon the response of the patient to this leukotriene receptor antagonist. So now this drug, these 2 drugs, and the other 2 drugs that are inhaled corticosteroids and LABA or long-acting beta agonists. Till fourth step, we were using these inhaled corticosteroid and LABA in separate inhalers. But in fifth step, we'll prescribe an inhaler which contain both of them, inhaled corticosteroids and long-acting beta agonists in a single inhaler will be present. And this inhaler will be used for maintenance as well as for reliever therapy. Maintenance is that daily fixed dose of morning and evening, and reliever mean whenever the person or the patient got symptom, then he will use this combined inhaler for the relief of the symptoms. So SABA plus minus LATRA and a combined inhaler that contain ICS and LABA for maintenance and reliever therapy.